Hello everyone, welcome to eLearn 16.3 and we're going to be talking about oils and such. At this point, I want to introduce to you the concept of metabolic syndrome, which are considered additional risk factors. So there are a few hallmarks that we want to explore further about metabolic syndrome. And one of them is really the fasting blood glucose that is more than 5.6 millimoles per liter. If you want to convert that to the US units, you have to multiply it by 18. The person would present with a large waist size, like the picture, the silhouette in the poster over there. Thirdly, they could have high blood pressure, sometimes maybe borderline high, may not be overtly high, maybe about 140 something or 130 something. And fourthly, they could have triglycerides, that's more than 1.7 millimoles per liter. And if you want to convert that to US units, you multiply that by 89. Lastly, they could present with low HDL, and we remember earlier that HDL is what is protective towards heart disease. Now, any three of these risk factors together would comprise what we call the metabolic syndrome. And why is metabolic syndrome important? Well, metabolic syndrome now becomes an additional risk factor for us to consider treatment at an earlier time frame or a lower threshold with respect to blood pressure and or lipids cut off. With this slide, I want to explore hypertriglyceridemia, and some of the common agents that are used in Singapore are listed over here. Why the statins are in brackets is because you probably would have associated statin use with the LDL lowering, and triglyceride lowering as first line. Generally, people would think about fibrates. We'll explore this a bit later. Lastly, the group of omega-3 fatty acids probably worth some mention because I think, is probably the most common supplement that the laypersons use in public. And so as pharmacy students and pharmacists in training, I do think it's important for us to have a little bit of the knowledge about omega-3 fatty acids so that you could also opportunistically educate your layperson friends. Lastly, there is this group of drugs called niacin. I used to have that in clinical practice years back in the lipid clinic, and I used to like it very much because not only does it reduce triglycerides, it also increases HDL, which is a helper lipoprotein to clear LDL from your peripherals in the body. It is also cardiac protective. Unfortunately, niacin has been withdrawn from use in clinical practice in Singapore. What's the big deal about hypertriglyceridemia, you might say? Remember, triglycerides are called the ugly cholesterol, whereas LDL is called the bad cholesterol. The bad cholesterol has been associated with poorer cardiovascular outcomes, whereas for triglycerides, you've got to have it very high before there's risk of some health problems like pancreatitis. A cutoff of more than 5.6 millimoles per liter or 500 milligrams per deciliter is associated with acute pancreatitis. In order to interconvert, you multiply by 89. So what about acute pancreatitis? The exact mechanism of high triglyceride levels causing acute pancreatitis is not really very well understood. Now, acute pancreatitis due to high triglycerides level tend to be a lot more serious than other causes leading to acute pancreatitis. Now, the higher the triglyceride levels are, the more associated with severe hospital costs and increased incidence of complications, as well as permanent organ failure, especially pancreatitis. The pancreas can be permanently destroyed. It is also associated with prolonged hospitalization and higher mortality. Some definitions that you might want to see and know when you read literature is that high triglyceride levels are defined as triglycerides as more than 5.6 millimoles per liter or 500 milligrams per deciliter. For this, there's actually no suggested treatment goal. Whereas very high triglyceride levels actually refer to triglyceride levels of more than 11.2 millimoles per liter and or 1000 milligrams per deciliter. The suggested treatment goal is to keep someone at triglyceride levels of less than 5.6 millimoles per liter. So in the previous slide, we talked about dangerous levels of triglycerides. How do we then address those levels of triglycerides as less than 5.6 millimoles per liter? Now, the first step is to address modifiable causes of hypertriglyceridemia. So it could be clinical conditions, for example, overweight, insulin resistance or metabolic syndrome type patients, diabetes mellitus, especially if they are poorly controlled, any persons with alcohol consumption, particularly if in excess and if you drink a lot of beer, excessive sugar intake or food, very highly processed food in your diet, high saturated fat intake, and that commonly comes from animal fat. People with hypothyroidism, chronic kidney disease, and some nephrotic syndrome that's also associated with the kidney disease, sedentary lifestyle, sometimes even pregnancy, and people with lipodystrophy are commonly those who have got, say, HIV-induced problems like that. So these are clinical conditions that we can potentially try to work on. However, if they're on drugs that cause this problem, then we go to thinking about how we can minimize the doses of these drugs or switch them to something else. Some common examples include oral estrogens, and this could be in a form of oral contraceptives, or people who have got postmenopausal replacements, people who are on oral glucocorticoids that could mess around with the triglyceride levels. And remember, in the hypertension series, we talked about non-selective beta blockers as well as the risk of thiazides and some smaller risk with loop diuretics causing hypertriglyceridemia and some metabolic disturbances. And that's also why we don't combine beta blockers and thiazides as first line in treatment of hypertension without any comorbidities. The other group of agents that you commonly see are those used in HIV, for example, antiretroviral protease inhibitors, and some atypical antipsychotics, for example, clozapine, olanzapine, as well as risperidone. There are some other drugs like sirolimus and cyclophosphamide. So what's more important is to figure out how to manage these medications that could be associated with hypertriglyceridemia. In general, the principle is if there's an underlying cause, remove it. If you can't remove it, you minimize it. Now, if you cannot remove it and you need to minimize it and it's still high with the triglycerides, if it exceeds more than 5.6 millimoles per liter, that's when you need to think about treating hypertriglyceridemia with a drug. Step 2 will then to be looking into non-pharmacological advice, or what they call therapeutic lifestyle change, or TLC. This chart over here summarizes the various lifestyle as well as dietary interventions that could reduce total cholesterol, LDL, triglycerides, as well as increase HDL levels. Now, it's hard to tease apart a singular dietary change to pinpoint to that particular benefit that you want with the specific lipoprotein. So in general, we will tell our clients or patients to replace the animal fats with vegetable sources because polyunsaturated fatty acids could also reduce cardiovascular risk. Saturated and trans fatty acid have the greatest impact on LDL, meaning that if you take more saturated and trans fatty acids in the form of processed foods or in the form of animal fats, there's more impact on the LDL levels as compared to the polyunsaturated type of fatty acids. Unsaturated fat oils can reduce LDL by 0.2 to 0.42, as well as a weight loss can also reduce the LDL. If you recall, the contribution of unsaturated fats in your diet plus weight loss can only modulate LDL by so much. However, if you try to reduce body weight and increase exercises, it actually it drops your triglycerides quite a bit. It also increases the HDL. Now, taking alcohol as well as carbo-rich foods, fructose and all can also be associated with increased triglycerides as well as abdominal obesity. So in short, avoid all these fast foods that's high in saturated and trans fats. Try to keep to more unsaturated fats from the vegetable sources or non-animal sources. Try to keep the weight down, and also, of course, to try to keep the regular activities and also regular exercise so as to manage the triglyceride and HDL levels. I thought this table was very useful. It tabulates food choices to lower low-density lipoprotein and improve the overall lipoprotein profile. Pay attention to the column on the left-hand side, which is to be preferred. And if you look at the column on the right-hand side, right, a lot of it would suggest that there's a lot of animal fat and contributions. For example, pastries, creams, and butter. If you look at how the lists there are, preserved meat, processed meat, as well as cheeses, trans fats like palm oil and coconut oil, which are actually very common in 3-in-1 coffee. So be careful to look out for those. Some of our locals drink quite a lot of these preparations, the 3-in-1 preparations. Sometimes even in the biscuits, like Kongguan biscuits, if you're careful to look, they also contain palm oils. Be very careful about those. The only misfit over there is really coconut, and this actually goes to show that coconut is very high in cholesterol, and therefore excess amounts of coconut milk in cooking should be avoided. I think the last column is a bit more localizable cooking procedures. We should encourage our clients to do more grilling, boiling, and steaming, maybe to some limited amounts, stir frying as well as roasting. But of course, limit frying as well as deep frying, because that will involve a lot of oils and thereby leading to a very unfavorable lipoprotein profile. Let's cover the fibrates now. The commonly used fibrates in Singapore include Phenofibrine and Gemfibrozil. And here are again screenshots taken from MediView. There are several preparations of Phenofibrate in Singapore, so be very careful to read the labels as well as instructions carefully when packing or dispensing Phenofibrate to your patients. You can go to MediView to have a look, and the link is over there. Now, the clinical effects of fibrates are mainly to reduce triglycerides and increase HDL. So compare that with statins. Recall that statins are used to reduce LDL. So the fibrates are usually indicated when triglycerides are more than 5.6 millimoles per liter. Recall that step 1 was to really look at secondary causes. Step 2 was to modulate your lifestyle, whether it be dietary or weight loss or exercise. And then it was only step 3 that you think about treating, and we'll talk about what to treat with first later on. However, remember that fibrates are indicated when straight off triglycerides are more than 5.6 millimoles per liter. Now, Gemfibrozil has demonstrated improved CV outcomes, but not Phenofibrate, and both have not demonstrated reduction in CV mortality. There are some interesting bioavailability considerations, particularly with Phenofibrate. And Phenofibrate is actually made with micronization in order to increase bioavailability. That's actually making it into little micron granules so that the absorption is better. And that's why we have got preparations called Lipentyl Supra and Phenofibrate Lidose that's used in Singapore. Now, it's got to be taken with meals because bioavailability can be increased with a high-fat meal, but we certainly don't want to ask our patients to eat high-fat meals, right? So just make sure that you tell patients to take their fibrates with meal times. A reduction in triglycerides can be seen as early as 2 weeks, and it can be optimal in 6 to 8 weeks. So if you want to monitor how people respond to Phenofibrate therapies, you can follow the usual monitoring that we talked about during the LDL series. So some cautions to take note of. For renal dose adjustment, Phenofibrate is contraindicated in severe renal impairment, and the Gemfibrozil dose adjustment allows it to be used in severe renal impairment. For these creatinine references, you will have to know a bit more in renal next semester before you can completely understand it, but just realize that these are indicators of severe renal impairment. For the ADR profile, both of them are associated with liver toxicity as well as myopathy. Now, there's also some purported drug-drug interaction with statins, and this was seen earlier on with Gemfibrozil because it's the older fibrate. Later on, when Phenofibrate was out in the market, there have been studies that look at Phenofibrate and statins together, and there has not been an increased risk of myopathy with Phenofibrate used with statins. However, there's still that need to monitor patients carefully, particularly with the risk factors that we talked about in the earlier series on being female, renally impaired, etc., etc. Always watch out for drug-drug interactions. Now, this Phenofibrate is actually associated with serum creatinine rise, and therefore there was some suggestions that Phenofibrate could be nephrotoxic as well. However, I think that it's not that dangerous nor serious, so it's just probably important to think about repeating serum creatinine for those who are at risk. So how do we monitor? Basically, LFTs, as mentioned earlier in the chart, in the small screenshot over there, just to remind you which chart I was talking about, and that's going to be in EL 16.1. If patients are renally impaired at baseline or at risk of renal impairment, then you might need to monitor their serum creatinine a bit more frequently. Now, remember that when you use statins, you don't need to serially repeat LFTs. You only need to do it at baseline and if you suspect there's any problems. However, if you're using fibrates, then it might be necessary to repeat LFTs at regular intervals following the starting of a fibrate. The relationship between cardiovascular disease and hypertriglyceridemia, I would say, is quite complex. Why? Because biologically, hypertriglyceridemia can cause perturbations of the lipoprotein homeostasis. By right, it can mess around even with your VLDL as well as LDL homeostasis. Epidemiological studies have also associated triglyceridemia that's increased risk of first ASCVD event. Yet, use of statins and fibrates together failed to show significance in clinical trials. So the REDUCE-IT investigators have found that if you add icosapent, 2 grams BD, they can actually, on top of statin, reduce the risk of ischemic events by 25% if people have a fasting triglyceride level of 1.5 to 1.6 millimoles per liter. Now, lower doses of 1 gram per day has not been effective for primary prevention based on the VITAL research group that's looked at the use of omega-3 fatty acids in the prevention of cardiovascular disease and cancer. That segues nicely into the fishy tail of omega-3 fatty acid. The active content of these preparations usually have eicosapentaenoic acid, EPA, plus minus docosahexaenoic acid, DHA. Now, you will commonly see it being written in literature as N3 acid ethyl esters, or O3-AEE. The only preparation that is available in Singapore is Omacol, and it contains EPA at 460 milligrams and DHA at 380 milligrams per capsule. Now, the other preparation is icosapent ethyl, or IPE. It's an ethyl ester product of EPA but does not contain DHA. The brand name is Vasipa, but this is thankfully not available in Singapore, and therefore you don't really need to know it so well. The clinical benefit of omega-3 fatty acids would include really lowering triglyceride levels, and that's what we usually use them for. The higher the baseline of triglycerides, the more lowering of triglycerides you would expect. Now, for Omacol, if you use 2 to 4 grams a day, it can actually fool the liver into synthesizing less triglycerides, and therefore the amount of triglyceride lowering can differ according to the baseline, and if you add on to phenofibrate, the total amount of triglycerides lowered together with phenofibrate could be up to 60 to 70% even. That's very, very impressive. Some of these preparations can cause an increase with LDL in some patients, particularly in the type 4 type of hypertriglyceridemia patients, and this was thought to be sensitive to the DHA components, so it was thought that perhaps Vasipa will not be associated with this problem. Now, the CV outcomes was reduced by the Vasipa population, as you have seen earlier, and reduced it, but it doesn't seem to be modulated at all or reduced at all with the other omega-3 fatty acid preparations, yet it's associated with new onset atrial fibrillation, which was thought to be dose dependent. So one needs to be really careful about asking people to routinely take omega-3 fatty acids, and probably it should be used only as an addition to phenofibrate if additional triglyceride lowering is required. And remember, the threshold for which we start to treat triglycerides is when it's more than 5.6 millimoles per liter. For counseling, you might want to tell patients that they would experience a fishy taste, eructation, which is actually burping, diarrhea and nausea, commonly GI side effects, and they have to take it with food because it increases bioavailability of these preparations. Now, remember that the OTC, or over-the-counter preparations, are not standardized, and they may contain large amounts of other types of saturated fat in order for them to formulate those supplements for people to be sold. Now, these are some examples of the supplements that's sold over the counter, 21st Century, and there's also Sharkly. You might also see GNC. Basically, I've clipped out a label on the site for you to show you the contents of a Sharkly bottle of EPA and DHA. Now, at the bottom, you can see that there are other types of fatty acids that's formulated with each capsule. Sometimes it's for the stability, sometimes it's also for the way that the formulation is. Now, this is how you can actually see that the over-the-counter ones can contain variable amounts of the other types of fatty acids. And we talked about how the saturated fats are going to be harmful for our patient's lipoprotein profile. And remember, you're taking fat, really sheer amount of fat. So you're going to be able to put on weight, right? If you take like all these fats, then you don't really know whether it's going to be helpful. So counsel the laypersons that you see, clients that you see accordingly. So just also to note, right, there's been a purported increased bleeding risk when used with antithrombotics, which are comprised of antiplatelets like aspirin and clopidogrel, as well as anticoagulants like warfarin and rivaroxaban. However, that has not been seen in clinical practice, and it's never, even in clinical studies, been associated with an increased risk of bleeding, and therefore that risk remains theoretical, mainly because omega-3 is thought to have antiplatelet effects. Now you know why it's a fishy tail? So with this slide, I just wanted to recap the TG lowering potential of phenofibrate. It can be up to 50%. And the effect of omega-3 fatty acids, again, is dependent on how high the baseline is. The higher the baseline, the more the reduction. And it can actually, together with phenofibrate, reduce triglyceride levels up to 60 to 70% when used in combination. So remember that niacin is no longer available in Singapore, and so you don't need to memorize it. However, if you ever go to practice overseas, you might see it. And so it might be important to know the effects of niacin as well with respects to the triglyceride lowering in potency. Summing up, here's an approach to hypertriglyceridemia. We're saying that we need to first exclude secondary causes and then institute some therapeutic lifestyle change or TLC. And the European guidelines is recommending adding statin treatment to those with high-risk individuals with hypertriglyceridemia of levels even as low as 2.3 millimoles per liter. I can't see very many clinicians who will be doing that routinely actually. For people who are high risk, what they're recommending is to basically think about adding IPE in combination with the statin if the TG levels lie between 1.5 and 5.6 millimoles per liter. This is likely to be influenced by the findings of the earlier studies that we talked about earlier. For primary prevention, meaning they haven't developed any sort of ASCVD yet, the recommendation is to have fenofibrate or bezafibrate added on to statins if the triglyceride levels are more than 2.3, and this is the same as the recommendation for high-risk patients as well in combination with statins. However, I would say that the level of evidence is not very high, and even if someone who has got high cardiovascular risk with triglyceride level of more than 2.3, I can't see very many clinicians adding fenofibrate on or fibrate on for that reason. Potentially, you might want to think about holding off for a little while. And I would think that the reasonable level to start anyone on treatment would probably be still when they're at danger, which is more than 5.6 millimoles per liter. Just to contrast that with the MOH clinical guidelines for you to have a look, basically they have got a primary prevention and an at-risk population. For the primary prevention, they are citing the levels of 4.5 for once MOH is more aggressive than the prevailing Caucasian guidelines, and they are suggesting to treat if the TGs are higher than 4.5 millimoles, and especially if the levels are more than 10 millimoles, because they have the risk of acute pancreatitis. Now, the people who are at risk are considered the ones who have got whole low LDL and males, as well as triglycerides being more than 2.3. And if you recognize this, it's a collection of what we call metabolic syndrome that we went through at the start of this series. So this is a recommendation for consideration to add on to statins for very high risk or high risk patients. Again, I can't see very many clinicians doing that in clinical practice, and therefore I would think that the compelling reason to add a statin is when the TGs are above 5.6 millimoles per liter, and only if you can't get the TGs to go at less than 5.6 millimoles per liter, you might want to think about adding omega-3 fish oils. However, because the IPE of Vasipa is not available in Singapore, I'm not that sure that I could recommend that Omacor should be added outside of its indication of lowering triglycerides, and that is the primary reason why I would have used Omacor in Singapore. Capping this whole series off, I just wanted to bring your attention back to the monitoring scheme for patients on lipid-lowering agents, and this particular chart is also relevant for people whom we've put on hypertriglyceridemic type of anti-triglyceride agents. And the only consideration when someone is on a fibrate on top of a statin is to think about routine repeating of the liver enzymes like ALT. Now, the lipids, as we've discussed earlier, you can repeat them at the same interval as you had intended to repeat for LDL. However, some labs these days don't really have triglycerides inside the panel. If you basically want to see an accurate level of triglyceride level, it's important to tell our patients to fast overnight, because remember, triglycerides are affected by intake of food within the 8 to 10 hour period of the testing of the blood.